Hit live stream, and then I'll share my screen here. Oh. Josh, should I just get going? Okay. Okay, welcome everybody. Thank you for joining us tonight. We have some members on our panel here tonight, and I know we have many members watching live streaming on Facebook right now. Thank you so much for joining us. My name is Conrad Amenta. I'm the Policy Director at the California Academy of Family Physicians, and this is the latest iteration of what we're calling Community Conversations. We're in a pretty unique moment here with the COVID pandemic, and we want to give an opportunity for members to share their experiences with one another and to learn from one another what they're doing to transition into new care models, to safeguard the financial sustainability of their practices, and to care for their patients and their own wellness and resilience. Tonight, we're going to be focusing on member experiences of telehealth. I should mention that we are going to be recording this. So this webinar is going to be available afterwards as a recording. The other thing is that you're able to claim CME credit for this, for the recording. So what we'll do once we share the recording, you'll be able to claim one CME credit, and we'll provide instructions on how to claim that credit as well. So let's get started. This is a thick text of resources, and I don't expect you to write down these URLs. I just wanted to put in front of you a snapshot of the shifting landscape, because we've seen more changes, I think, in telehealth in the last 3 weeks or so than in the 40 or 50 years before that. It really feels like there's been a huge paradigm shift, and it's happening at the federal level. It's happening at the state level, and it's happening in the private and commercial insurance market. These resources we're going to post in the comments under the live stream. So if you're watching this on the live stream right now and you're thinking, how am I going to get these resources? Because this looks like it could be useful. They should show up in the comments underneath the live stream. The other place you can find these resources is on our website, familydocs.org. I'm not going to go through each of these in turn because there's a lot of detail here, but I wanted to point out some of the common themes and a lot of what we're seeing. And things are changing literally day to day. So we made this slide about a week ago, and I've been adding resources to it almost every single day. What you're going to see across Medicare policy, or you're going to see across Medicaid policy and in the commercial market, you're going to see an emphasis on flexibility. People can use almost any platform they want to use. They can see the patient wherever they are. When it comes to training, you're going to see some of the supervision rules relaxed so that in-person supervision is not necessarily required for telemedicine visits. You're also seeing a real relaxation of the privacy policies. Both state and federal privacy policies are being either suspended or the enforcement of those. There's a forbearance from enforcement if telehealth is being used in good faith. Now, there isn't uniformity across each of these levels yet. So federal, state, commercial insurance market, they're not all exactly the same. And for example, we just heard the other day that, that in the Medicaid market, a telephone-only visit is now being paid at parity with an in-person visit, but that's not in place yet on the Medicare level. Our national organization, the AAFP, submitted a letter alongside a number of other national specialist societies calling on CMS to pay for telephone-only visits at parity with in-person visits. So this is not an exhaustive and authoritative list, but the themes you should be aware of is that we're moving very quickly towards parity across platforms, and there's a real relaxation of those privacy rules. All of these resources you're going to find, I made sure under the initiatives you should be aware of, but the AAFP resources, there's a telemedicine, telehealth resource center there. You're going to find all the latest. You can also go to our website, familydocs.org. So this is I'm pointing at my screen, but you can't see where I'm pointing. That doesn't work. So the AAFP website, there's telehealth tools section on their COVID page. Really encourage you to click on that. Coding and billing, transitioning. If you don't know what platforms you should use, they don't endorse solutions, but they do say, here's a bunch of platforms that members are using. Other family docs are using these. So if you're starting your transition to telehealth, everything you need is right there. You can also go to our website at the CAFP, familydocs.org. Right on the main page, you're going to see a banner, and you can go to our COVID resources page. And something you're going to see here is a series of surveys you can fill out. Let us know what you're experiencing. And that is absolutely crucial for us to advocate on your behalf. If you fill out these surveys, those results help us advocate for you in Sacramento. So please check out our websites, both AFP and CFP, for the latest resources. And once again, on the Facebook stream, you should see those in the comments. Oh, one last thing. Spark is our member-only message board. You see the link there, spark.familydocs.org. If you haven't logged on, you should. All CAFP members have access to that. So you have access to 11,000 other family docs in California. You can ask questions of one another on there. There's a great conversation. There are a lot of great conversations happening right there. So I really recommend you go on Spark. And finally, Campus is our CME platform. You can find it on our website under the Education tab. If you're looking for CME right now, go to Campus. You'll find exactly what you need and all the instructions about how to claim that. So we have a panel here for you tonight. Thank you for bearing with me as I go through those resources, but you're here to hear from other members, and we have 5 wonderful members who've taken time out of their evening to join us tonight, and I'm gonna ask them to introduce themselves. They represent a diversity of practice models. I'm gonna ask them to introduce themselves, and I'm gonna ask them to answer these 4 questions by way of introduction, so we can understand a little bit about their experiences before we open it up. So we're gonna ask you to introduce yourself, describe your practice, what telehealth platform are you using, if any, and how long have you been practicing telehealth? So we have 5 of our members here tonight, and I'm gonna start with the chair of our Medical Practice Affairs Committee, Dr. Larry Shore. Larry?
Thank you very much. It's nice to be here. I'm Larry Shore. I'm a family doctor. I've been practicing in San Francisco since 1981. I have been in a variety of practice settings. Prior to this, I was in a small group practice, 4 family docs and a couple of nurse practitioners. Unfortunately, that practice went out of business just a few months ago, which led to me joining a very large group practice associated with the Sutter Hospital. It's called the Sutter West Bay Medical Group. And I'm now in a practice with 5 physicians in the Mission District of San Francisco. We have been experimenting with telehealth for about 10 days now. We started out with a short-lived experiment with an embedded system within Epic, and quickly moved on to Canto, which is the iPad version of allowed to use FaceTime, although I think that one is somewhat frowned upon for the future. So going forward, it'll be primarily Canto, WebEx, and of course the telephone. At the beginning, each visit seemed to take forever because there was a lot of fumbling at the beginning and fumbling at the end, but I think we're beginning to get it more grooved now, where the medical assistants have been trained on how to set up the practice, set up the visit so that we can simply just log on and get started.
Great, thanks, Dr. Shore. Let's move on to Dr. Shannon Connolly.
Hi, everybody. My name is Shannon Connolly. I work for Planned Parenthood of Orange and San Bernardino counties in Southern California, and I oversee our primary care service line, which is 7 clinics that do just general primary care. We've been doing telehealth now for about 3 weeks. And we also did a pivot. We initially used the program that comes with our EMR, which is eClinicalWorks, and it's a suite called Helo. We discovered within 3 or 4 days that that wasn't going to meet our needs, and so we quit using Helo and we started using Docsy.me, which is actually available for free, although we have the paid version because it has a little bit more customizability. And things have been going pretty well so far. much like Dr. Shore, we had, in the beginning, there was a little bit of fumbling around with both of our different platforms, but we rapidly figured it out, and we're starting to really enter into more of the fine-tuning phase where, we're working on the little things. It's not just, can we get a patient and talk to them? We're now thinking about things like, what is the best way to implement certain things. A sort of unique twist for our practice too is that we have our own pharmacy and we dispense 340B drugs. And so we had to figure out a way to somehow incorporate pharmacy dispensing that is appropriately socially distanced. And so we also developed a no-touch pharmacy dispensing model that we work with telehealth. It's drive-through, so the patient comes and parks, and we confirm their identity. We do the telehealth visit, and then we send out somebody to deliver the medication to the patient before they then drive off. We started out, I wanted to call it drive-by pharmacy pickup, but fortunately our marketing department was quick to point out that that was the wrong terminology. So we went with drive-through. And we're looking at offering a variety of different express visits, including things like injections, where patients can come park in our parking lot, have a telehealth visit, and then a medical assistant or nurse will pop out and provide them with whatever they need with as minimal contact as possible. So.
Great, thanks, Dr. Connolly. From here, let's go to Dr. Janine Rodoms. Janine, are you there?
Yes. Hello.
Hi.
I'm Janine Rodoms, and I've been in a variety of different practice models over my career, but over the last, now we're going into our 5th year, we've been in a direct primary care practice that is a pure DPC. We have had, initially when I started this, we were utilizing a variety of different free or cheap EMRs with membership platforms that help with our billing side. That's a little different than the fee-for-service arena. But we presently use actually a really well integrated system that's called Hint Health. That's our membership platform that integrates with our electronic record, which is Elation, and integrates with our texting platform, which is called Spruce. We have been using Spruce as a texting platform and a communication platform for our patients now for 2.5 years. And we love it. We rely on it for communication with our practice as kind of a bigger platform than even phone calls or emails. And then about 4 weeks ago, when we realized that we were going to need some form of a video platform, we started looking into what might be available, but then realized that our texting platform had a little video button on it, and started utilizing the texting platform for our telehealth visits. We have to initiate it from our side in order to do these visits, but it's worked really well. This platform is a HIPAA compliant platform already, and it automatically syncs into our EMR at night. So we have been actually pretty fortunate to utilize what we had been using for the last 2.5 to 3 years.
Great, thanks, Dr. Rowe. I had one quick follow-up that I wanted to ask you, actually, just because I don't want to lose this question, but you said it syncs up at night, so it does a batch update at the end of every day, or is it?
Yes. At midnight, the texts, pictures, we have pictures, documents, text that usually go through that platform. It's documenting for us with the telehealth the time spent and the phone call that was and the call that was made. So we have that all automated into our electronic record. We're not having to reproduce that information. We do write a note for the telehealth that has to go into the electronic record, but all the texting activity actually is automatically uploaded.
Thanks. I know I'm jumping the queue. It's just I'm already getting questions I want to ask. From here, let's go to Dr. Michael Zimmerman. Dr. Zimmerman, are you there?
Hi. Yeah, thanks for having us. Great discussion. Nice to see some familiar faces there. It's been a while since I've been in deep with CAFP, but good to be back in the mix. So I am obviously a practicing family physician, current practice has been around for 11 years, called Temescal Creek Medicine. It's just myself and another primary care doctor. We have a panel of about 1,500 patients, 20% Medicare, 20% HMO, and 60% out-of-network cash on the barrel PPO work. We have been doing scheduled telephone visits since the start. We believed that that having scheduled dedicated time and a capability to do that as a scheduled visit and be reimbursed for it was essential. And so we've been doing that. We pivoted, of course, in the last, literally on the 15th or whatever that was, to going to predominantly 95% telehealth visits and really only seeing the people that we have to see in the office for critical physical examination assessment needs. That's been our experience. It's been, pretty slick. I'm also the chief medical officer for Canvas Medical, which is a cloud-based, fully integrated primary care technology suite that has all of this fully integrated, secure patient text messaging and what we call virtual exam room.
Great, thanks, Dr. Zimmerman. And finally, last but not least, we have Dr. Warren Brandel. Dr. Brandel, are you there?
Can you see me?
Yes, I can.
Good. Well, hello. Hello, family doctors, fellow family doctors. We're super proud of all the work you guys are doing, and stay strong. We're going to get through all of this. I'm a solo family doctor. I did my med school and residency at UCD. Finished in '88. I was part of some urgent care programs for several years, and then joined a large multi-specialty dysfunctional medical group for a few years. And I went solo about 23 years ago. And my practice model has been exclusively outpatient. I don't do nursing home or hospital care. I have a full-time physician assistant. She provides a lot of our women's healthcare needs. We share call between the two of us. And I have 6 medical assistants that many of which have been with me for many, many years, minimum of 3 years for all of my staff, but as many as 15 years for several of them. So we've got really an amazing staff that have really focused on making this work for us. I'm in practice in Gold River, California, which is a suburb of Sacramento. So my perspective on this is going to be perhaps a little different in terms of the fact that I'm a sole proprietor. I'm not salaried. I've got staff payroll to meet and expenses to meet, and I've got to pay them on my own. So some of my focus on telehealth has been making sure I'm reviewing all the appropriate telehealth codes that are available, HCPCS codes, HCC codes, all of the normal coding that can involve billing and some reimbursement for the services I'm providing. So that's been somewhat of my focus, as well as trying to provide, high quality patient care on a remote basis to my patients, which can be challenging sometimes when you're dealing with musculoskeletal conditions or dermatology, respiratory symptoms, etc. I have about 2,500 patients, somewhere in there in my practice. Probably half of them are members of Hill Physicians Medical Group, a very large independent physician association that has both HMO and PPO patients. I have probably 40%, maybe even larger percent of my practice are seniors. I'm 67, and I think they've grown older with me. And that was one of the reasons that back on March 22nd, over the weekend on a Sunday, I made the decision to go virtual. Spoke with my office manager how we could make it work, and the next morning we went live. It's been a wild ride. Lots of details I can share with you in terms of how we're making it work. I could save some of that for our open discussion, but it's a lot of variety, a lot of diversity, a lot of personal challenges of our staff. But we're just a super strong team and communicating well, and I'm the virtual doc from home and have no backup. So I got to take care of a lot of people here, and it's safer for me to be here than to be seeing somebody in my office with knee pain or a shoulder pain or whatever. So there are some challenges, but we're adapting every day. So I'll leave it at that.
Thanks so much, Dr. Brandel. Did I hear you right? You made a decision on a Sunday to do it, and on Monday you went live?
Yeah, I don't have any administrators I have to get approval from. I don't have anybody else's opinion other than mine and shared decision making with my office manager. I had to lay off my physician assistant at that point because I had no office hours for her, and I really don't want my staff being exposed from asymptomatic carriers. So we're running a locked office. I've got all 6 of my MAs full-time on the phone all the time, calling patients, taking care of details, prepping charts, getting me ready for my video visits. So it's labor intensive, but we're finding plenty of work for everybody except for my PA. Yeah.
So I just want to pause here for a second to note that we have a lot of people who've joined us on the Facebook Live stream. So thank you, everyone who's watching this right now. Thank you so much for joining us on your Thursday evening. If you have questions, there's a little bit of a lag between us recording and it showing up on the live stream. So if you have questions, you can put them in the comments underneath the live stream. Our staff is taking a look at it. They'll make sure the questions get to the panel. So there's a little bit of a lag though, so maybe start thinking about that now. Yeah, please don't hesitate to put your questions in the comments under the live stream. So from here, I want to open it up to have kind of a panel discussion. And I've just come up with these key questions, but I don't want to constrain the conversation or keep it from going where it needs to go. And I feel like we've already started to get into some of this, what has worked, what hasn't, what surprised you. I've been jotting down as you guys have been talking about. I've been hearing a lot of trying something and then pivoting to something else. I've heard a lot about integration with text and EMRs. Cloud-based software. And I'm also super curious to know what proportion of telehealth to live each of you are seeing. But I'd like to open it up to you guys to share your experience. Maybe we can go in reverse order because Dr. Brandel, I feel like you're just getting rolling there, and I was really interested to hear more about that. Do you want to get us started? Is there one of these questions you might want to that feels natural to jump to?
Sure. Well, the first question is what's worked. I think that's probably critical. It took a little bit of planning as we were, on the fly, just going along as well as we could day to day. But I use WhatsApp for my video visits, primarily because right now it doesn't have to be HIPAA compliant. I'm really not worried about the federal government chasing me for making a WhatsApp connection with my patients right now. And when the crisis is over and those regulations are lifted, we're really focusing on trying to get our patients onto our Hill Physicians medical group version of Epic using my Hill chart. And we use that already for some patients that are able to get on. But frankly, WhatsApp is a lot easier than my Hill chart for getting patients ready to go. Despite that, it is extremely labor intensive. Calling a patient that contacted me, the way I do our triage, all phone calls coming into the office are directed to me, into my inbox. And then I evaluate every call coming in with any person with any symptoms or any concerns. And I get back to my staff. I have a variety of templates set up that I just hit a few buttons and say, set them up for a telehealth visit, or, okay, we'll fill this prescription and we'll check your labs when the crisis is over, whatever. So consequently, I bought a burner phone and I use that exclusively for WhatsApp use. And I don't put any patient names into my personal WhatsApp phone that I use to contact my grandchildren who live in Bali. But I use the burner phone for all of my WhatsApp not data entry, but patient names and phone numbers. So that has worked well. And then when we're ready to go for our video visit, my medical assistant is also my scribe, which it's always been the way I've worked in my office. I've always had my scribe in the exam room with us, documenting and recording the visit. So she's on my phone, listening in onto the burner phone for the patient's conversation, and I get the visual face-to-face communication with a patient. It's made it very convenient. I can tell you, I actually crunched some numbers In our first week, we did 64 virtual visits. In the second week, we did 94 visits. And this week through Thursday, I've done 86 television or telehealth visits. And out of those, there were 200 out of 244 of the encounters that I saw patients for, by either telephone or video, were video visits. So I did 200 video visits in the last 14 work days. So it's been, but you know what? I was done at 3:30 today, and I had my charts done. I had the refills taken care of. I had patient callbacks done, reviewed my labs. I come into the office in the evenings a couple of times a week and catch up on paperwork and signatures. So that's sort of what my day is like now. I'm, sitting here at home and just calling patients and meeting with them. So that's what's worked. I've got a great staff. We're constantly communicating with each other. We're solving problems on the fly like all you guys are. Also, we sent out a newsletter on day 3 or so, once we went virtual, letting all our patients know what's going on. I'm also capable of doing e-blasts when an updated newsletter, letting people know, any issues that have changed and how we're operating things. So it's all about communication, and our staff are on the phone constantly through the day, either calling patients, making sure they're doing okay. Do they need refills on anything? It's all about communication, and we spend many work hours every day just doing that by telephone. But our telehealth visits are pretty darn functional. The way I work it is that my staff, when they know I've got a patient scheduled, they do extensive pre-charting. They go through any care gaps they have. They review any HCC codes that we need to review. They review any HCPCS codes that have not been generated for the year. So by the time I'm ready to go, my MA has just called the patient just before our time or appointment time, saying, "Hey, Tom, Dr. Brown's ready to go. Are you live on WhatsApp? Open your application. He's going to call you in a minute." That has helped, because otherwise there's communication problems sometimes where looks like they're on WhatsApp, yet when I press the button to do a video visit, they're not connecting. So we have to call them back. So this has been one answer to that difficulty. And even then, it still doesn't work all the time, as I'm sure many of you people are knowing. So that's really what's worked the best for us. The telephone visits are truly the easiest, because they don't require 10 to 15 minutes of my staff time to get them enrolled into my Hill chart or onto WhatsApp, especially our seniors. It's extremely difficult for them. So I'm fine with doing telephone visits for them as well, unless they have musculoskeletal problems, respiratory symptoms, skin rashes, and a bunch of other things that are hard to sort out by without putting hands on. But so far, I've tried to just find a balance there of who needs to be seen, who needs to go to the emergency room, and who can we take care of at home, and that with that strategy. So that's what's been working for me.
Great. I actually, for the group, I'd like to add 2 more questions for consideration to this list, and I invite anybody to jump in who wants to jump in next. We've got some questions coming from the Facebook live stream, so this comes from the live studio audience. So one question we received was, when you were selecting your platform, and I see Dr. Connolly, you already answered this on Facebook, but when you were selecting what platform you wanted to use, even though we're in this unique moment where HIPAA compliance is not being emphasized, were you selecting your platform thinking about the post-COVID moment where theoretically we return to some semblance of HIPAA adherence? That's question number 1. Are you thinking about that when you select your platform? And question number 2, a little bit more general, what is the number of telemed visits that an office should strive for? I assume that's kind of practice specific, but I wanted to add those to the list. So yeah. I'm going to open this up if anybody wants to grab the baton and go next.
I would comment in, so with regard to HIPAA compliance, I mean, there are very easy HIPAA compliant options. We opted for the Zoom platform under an organization that already had an existing BAA with Zoom, which allowed for a real, just very seamless plug and play experience. And I think one thing I would say that's essential, and just for people to understand what I call the virtual exam room as simply that, an extension of what traditionally would have been exam room 1, exam room 2, virtual exam room. And your schedule in the future may just be a mix of those. Hey, from 2:30 to 3 o'clock, you're in the virtual exam room. From 3 o'clock to 3:30, you're in exam room 1. And just blow up the whole concept and make it just another extension in which you, as appropriate, can see patients. The other comment I'd make is there's the blessing and the curse of integration, quote unquote. And I think that the ability to have a freestanding platform in which you can have these communications while completely being able to operate unfettered in your electronic medical record is liberating and very important. I think a lot of the problems with current solutions on the market that are solutions is they're partial solutions. They might have a scheduling thing and a text thing, but as somebody, I think it was maybe Morgan pointed out, at the end of the day, or it was Janine, it requires some like retroactive reconciliation. Whereas if just give me unfettered access to my EHR and let this go on the side, that way I can have access to the documentation I need, but more importantly, to the database upon which I'm querying the patient, right? There's no such, like, we're getting interval history, we're querying a database to triangulate against that information to come up with appropriate assessment and plans.
I would like to agree with that. That's been my experience also, that having the laptop in one place and the iPad next to it allows you to do two things simultaneously, neither of which interferes with the other. And I completely agree that you need to integrate the virtual with the actual in whatever way flows for your office.
Yeah. I know, for example, there was a lot of, I'm sure people had questions about Zoom, and there was the Zoom. I mean, we had a very wonderful Zoom bombing experience on the CAFP, didn't we? That was my first, by the way.
Mine too.
That also goes to show you that people don't really look at all the settings of something like Zoom before they use it. I mean, right away, enabling personal meeting room, labeling personal meeting room with Dr. Zimmerman means anybody can say, join a meeting and type the word Dr. Zimmerman, and they're in my waiting room. And when they're in my waiting room, I have 100% control over who comes in and who doesn't come in. I can invite grandma and the daughter. I had a specialist friend the other day who happens to be doing virtual medicine. I texted him and said, hey, can you join my call right now? Because I got a person I want to talk. He jumped on the call and we had an appointment with the patient. So unlocking all of those possibilities are within the tool set. And I've been very happy with Zoom. I'm sure other people have other solutions. My one secret best practice is use the personal waiting room. So your link is always the same, but enable personal waiting room, and you will have control over both people are coming in as well as the ability to kick people out.
Well, I'm glad that our experience the other night could produce some insight and, and some continuing medical education value for our members. I just got a really good question actually from the Facebook stream. I wanted to introduce it, and I invite anybody to jump in and answer it. How have you gotten the less tech-savvy populations to sign up for telehealth? Is there a certain strategy you've used, a certain platform? Do you have any tips for our members out there who might be skeptical that they can get their patient panel to meet them where the care platform is?
I'd be happy to take this one because this is actually why we had to pivot from one platform to another. Our initial platform required that a patient receive an email, click on a link, download an app, and then sign into that app and create a profile before they could have a visit. And that was just too much for my patients. We had like a 30% success rate. And once we realized that that was just not going to work, we began searching for a platform that was much more user-friendly and intuitive. And our specific goal was we wanted to try to find something that didn't involve having to download anything. And so that's why we ended up with Docusign. And the way it works is we text message the patient a link. And all they have to do to start the encounter is to click on that link. And we found that most of our patients were okay at receiving a text message, and we could be on the phone with them and say, okay, see that thing that looks like a bunch of letters, touch it on your phone.
Yeah.
And that was we were able to get our patients in that way. We also learned early on that it's really important to be able to pivot quite rapidly. And, you know, as healthcare providers, we don't have time to spend a lot of time trying to sort out IT issues. And especially since we see primarily Medi-Cal patients, and because there's pay parity, we have a very low threshold for converting a telehealth video appointment to just a regular old telephone appointment. And so we've told our providers, if you're not face-to-face with your patient within 3 minutes of the start time, just pick up the phone and call them. And that, I think, is a really important thing, because otherwise you will fall behind in your schedule. You can't get things done. It's very frustrating for patients. A lot of times it has to do with the setting on their side, and you can't, you know, you can't troubleshoot their equipment. You can only troubleshoot your equipment. So I highly recommend having that capability. But, you know, and then the last thing I would just say is that, you know, we recognize that we are not reaching all of our patients. There's a tremendous digital divide, and, you know, we have patients who are homeless and don't have a telephone. And for those patients, we've had to create alternate pathways where we can still see them in clinic, because there's just no way to take care of them otherwise, and we have to take care of them.
I would also add on, in terms of transitioning from a non-HIPAA compliant application like WhatsApp to my Hill chart. That is our goal, to be able to transition as many into my Hill chart, which, you know, once the crisis is over, will remain as our HIPAA compliant mode for communications.
It's a little different for me, being part of a very, very large organization where they wanted to start at the most secure platform first. So because of that, it's a little bit more cumbersome for getting people on board. And so we're allowing more time, both for us and for them, and scheduling longer amounts of time for these visits than we would face-to-face. But I expect that we will one day get a little bit more efficient. Maybe not quite as efficient as you are, but close.
What I'm hearing is that this flexibility to be able to pivot between platforms based on the members' needs is really crucial. And for those who might be just joining us on the Facebook stream, I wanted to point out again that the AAFP joined a number of other national specialist societies in calling on CMS to reimburse for telephonic encounters at parity. So that sounds like it might be a useful policy to have going forward, where if you're really having trouble getting them on the platform, saying, you know what, let me give you a call right now, and it doesn't mean foregone revenue and challenges to the sustainability of the practice. Dr. Rodhams, I wanted to ask you to weigh in here, because you know, the moving to a DPC platform and having that or DPC model and having that integration feels like so crucial, so that you have that nimble communication with your membership. Is there anything that has been particularly surprising to you as you moved into a direct primary care model and started to rely on telehealth, you know, well in advance of the pandemic itself? You know, is there anything that was really surprising to you as you were starting to work on telehealth encounters?
Well, when we initiated the texting platform, I don't think we realized how reliant we were going to become on that platform for our communication. It is just so convenient to be able to basically blow the walls of the clinic out and not really require patients to be in front of you with looking at a rash, telling me what some symptoms are, communicating through an iPhone with a mom who's at work and a child who's ill. You know, the convenience and the amount of actual work that we could do through that platform was surprising, to the point now that, you know, even though we're using Elation as our EMR, and there are, you know, as we all know, every EMR has its difficulties. Trying to come up with the EMR that still integrates with the texting platform like Spruce, it has been tough. We won't give up the Spruce in order to find a separate EMR platform in order to do our work. It's just too critical. So, in terms of some of these issues over, we help our patients to be able to bring the app down. Most of them are pretty proficient. Once we get it going, we have staff members who help them as well, so that once it's on their phone, we can get started and communicate and continue through that pathway. We still, as Shannon noted, still have people with flip phones. We still have patients with no phones. We have seniors who are in their homes. We do phone calls, and we still do home visits if we need to for acute issues. We are still currently seeing patients in our office. We have the day segregated out into urgent, more well versus potentially serious, urgent in the afternoon, where we are gowning up. We are doing the car visits so that we kind of keep those two populations separated. But we are a direct care practice, so we don't have the scheduling issues. Our day is an 8 to 10 day patient day outside of what's happening now. We do 30 to 60 minute visits. Right now, we've kind of actually reduced that to 15 to 30 minute phone or telehealth visits, still seeing that 8 to 10 patients a day as a part of our usual model.
Great, thanks. Two awesome questions just came in. I want to make sure I put them in front of the panel. What kind of training do you wish you could have had before all this surge in telemedicine happened? Is there any training you wish you had? And secondly, do you think that your office will be able to continue doing telemedicine at this rate once the crisis is over?
I would, this is Dr. Zimmerman, I don't know that there's any training. I mean, I feel pretty tech capable. And then the other phenomenon I'd point out is, frankly, there's been a lot of community education around telecommunication, period. Having been on the phone with my mother and Facebook and figuring out how to push the right button at the right time. I mean, there are others doing our education in terms of facilitating the stuff that we need, which is actually a unique occurrence, right? We're not the ones having to train patients exclusively on a platform. And in that regard, actually, you might argue that using platforms that are more commonly used and have HIPAA compliant options outside of healthcare are in fact advantageous. The other thing I'll point out with regard to the question of, how much are you going to continue to do? Listen, I'm in family medicine because longitudinal relationships matter, and longitudinal relationships will always matter. The reason I am able to be as effective as I am right now is because I have patients that I've known for up to 20 years now at this point, and my ability to carry on a conversation via video is massively facilitated by the relationships that we all as family physicians value so highly. Are there some things that you, in the future, with this being easy and reimbursed, could and should be doing? Absolutely, right? Follow up, we do telephonic right now, follow up depression, start a medicine 2 weeks later, follow up, hypertension follow up, anything that doesn't require a physical examination. But I also do want to point out that physical examination matters. And as I believe somebody else pointed out, there are things that a rash that's got an induration to it is a rash that doesn't. And you need to put your hands on that kind of stuff. So I anticipate that going forward, there's going to be probably 35% of our visits could and will be continue to be virtual, but our mainstay is going to be in the office, not because that's for me, but because I think people actually often like that relationship.
I can comment on that as well. Because I'm part of Hill Physicians, we have my Hill chart. They have been working with us significantly to improve our ability to be using a video visit through their patient portal. And that is our long-term plan, is to transition anybody using WhatsApp into a My Hill chart. They don't have to be a Hill Physicians Medical Group member in order to use my Hill chart. So that is absolutely the plan. And I'm learning as I go along that video visits are very efficient for many things. You know, actually less time consuming. You know, I was just mentioning earlier, I saw, 20 patients on video visits today, and started at 8:30 and stopped at noon, started at 2 and was done by 3:30. So I'm actually more time efficient, especially with the way my staff are pre-charting and post-visit, post-encounter charting. It's making me much more efficient. So I absolutely anticipate incorporating telehealth much more into my practice, having designated times, just as you're talking about, Dr. Zimmerman, about this is a time for virtual visits. And I really, and the patients like it too. They don't necessarily want to drive in their car and come down and see me and wait in the waiting room and all that. So it's very efficient. And the other, there was a question earlier about, what's the biggest surprise? There were two of them. One was how quickly we were able to transition from Friday seeing patients in the office to Monday morning being at home and seeing, 12 patients or so. So that felt good. But frankly, what's more enjoyable is the joy that I see on our patients' faces on a face-to-face visit during this crisis. They see me, I know them like you do. And, they've been my patients for 20 years. I know their frailties and their personalities and their styles. And they get great comfort out of knowing I'm there for them. I am available 24/7 if you need me. You call my exchange after hours, call my office during the day. I will speak with you one way or the other if needed. So that's probably one of the biggest strengths. And I hear that from my patients. Thank you, Dr. Brandel, for just being available for me. It's what we do. And it's the real positive sign, positive outcome of doing this way.
Yeah, I suspect one very strong dynamic in all of this, once the pandemic is over, is going to be patients becoming accustomed to this level of access and convenience, being able to use their consumer devices to contact their patients or their physicians across practice models. So that's something else to be aware of. I did want to ask Dr. Connolly if you could speak to a couple of the comments. I believe you might have put them on Facebook or just in the chat here, but you were responding to some of the questions you received about training, and I think these are really great comments. Would you mind speaking to those real quick? Great, thanks.
So I had said in answer to one of the questions that, I don't know that there's a specific type of training that one needs, because it really is just, you just take care of the patient. But I guess, you have to use your good judgment about what you can and can't do safely, and be really firm on that line. I also found very rapidly that it's really, really important at the beginning of a telehealth visit to ask your patient where they're located. And so I often start off my my calls or my video visits by just saying, like, hey, are you at home right now at the home address we have on file for you? And if not, where are you? And that's really important because we've had two cases this week. One of a patient who had acute suicidal ideation and we needed to send a CAT team. And another patient had really severe respiratory distress. And so I called 911 on her behalf to have her transported to the hospital. And so just in case of an emergency, it's good to know where your patient's located. That's a good one. And we routinely make sure we document that. Another thing, and I think this is something somebody else mentioned, is just because you're on a telehealth platform with your patient doesn't mean you can't still use all of the support of your staff in whatever they normally do. And so, I started out just trying to do it myself with the patients, and then I realized I really need my medical assistant. My MA is incredible. She collects so much information from the patient and really sets up the patient for the visit in our in-person interactions. And so there's no reason why she couldn't also do that for our telehealth interactions. And so, just like she normally triages my patients, she gets all their medications and their doses and makes sure the medical history is up to date and reviews what health maintenance they're due for. She takes care of all of that before I start the encounter. And that has been, it just makes a world of difference in terms of my ease of taking care of the patient. And then the last thing, and this is, I guess, a legal recommendation, is get some language that adequately documents legal consent. for whatever is necessary. In ours, I think it says that, you know, the patient is aware that our notice of privacy practices is available on our website, and the patient understands the limitations of telehealth and agrees to, you know, care using this modality. Our legal department felt very strongly that it was important that we added that language. And so we just have like a little button and it just drops that into our all of our visit notes. And I think that that's important, especially in a world where I don't know if a lot of you have capacity to have patients sign consent forms online. We unfortunately now do. So we just shoot them consents and they sign them and send them back to us. But if you don't have that ability, it is really, really important to document consent in your chart. And if you are looking for a way to have consents be signable online, I really recommend something called Docusign, which is a program and a platform that you can use for a secure encrypted signature for things like consent, things that you would normally do consent forms. So for me, I have a controlled substance patient agreement that I have them sign if I'm prescribing any controlled substances, and we can just send that off through Docusign.
Yeah, I think that's a great point. I would put out the flip side of that coin, which is I think one of the points of clarity that's come from this is how much regulation and legalese and the stuff that frankly doesn't matter and is getting in the way of healthcare on a day-to-day basis drives our thinking. And hopefully one thing that will come out of this will, listen, we all want and respect patient privacy. We all think that people should be, have consent and be informed, but it's gotten to the point where it was pre-COVID so burdensome and not rewarded to do any of this. This is behavior change 101. If you want somebody to do something, give them a reward for it and smooth the glide path. And those are the two things that I'm actually surprised happened. Amazingly, the government and payers in a matter of very short time flipped the switch and said, we're going to pay you for this and we're going to make it easy to do. And guess what? We did it.
Couldn't agree more.
Thank you.
I'd love to ask Dr. Shore to jump in here, because one of my first experiences after I joined the Academy of Family Physicians was I went over to Dr. Shore's practice, and he showed me his practice space and specifically how to arrange the computer monitor to continue to have line of sight with the patient, and really help to impress upon me the importance of workflow. And Dr. Shore has always been a leading voice with the Academy as the chair of our Practice Affairs Committee. So I'm putting you on the spot here, Dr. Shore, but I'm buttering you up first, so I hope you don't mind. And I'd love to get your perspective on, what tips would you offer to members in different practice settings as they're considering making this change? Oh, you're muted. How do we unmute you? There you go.
In my practice setting, we have a very interesting physical design where doctors don't actually have their own office to retreat to. We have a sort of an open bullpen setting where you sit next to your MA. So really the only place to have privacy for a video visit is in the exam room, which, by the way, aren't being used very much right now. We're about 75% video and 25% face-to-face. And so what I've done is to use the same setup I have, which is a small rolling desk with a laptop on the left and the iPad on the right. And I make sure to roll it around so that there's good lighting and nothing funny looking behind me. It's a funny thing to think about, but I did that for tonight too. I wanted to shift my iPad so it looked like I was in a clean, well-organized room, which is actually not true. And then I always ask them right at the beginning, can you hear me? And oftentimes I see mouth moving, but no sound. And so this is where I think having the phone for backup is a really great idea. Sometimes I've actually written on a piece of paper and hold it up to the camera, unmute your microphone. Doesn't always work. But I have been surprised and pleased at how much patients are accepting of it, and how much, I think as Dr. Zimmerman said and others said, when they see your face that they've seen for so many years, it really instantly makes them happy and relaxed and taken care of. I think, the blending of synchronous care, asynchronous care is a really interesting challenge going forward. and it puts into question some of the traditional payment methodologies, which have been basically primarily face-to-face, fee-for-service, RVU based. I think going forward, we're all going to have to take a hard look at this methodology and look for better solutions. Certainly direct primary care is one of them. And with direct primary care, like in capitation, you get sort of advanced payment to take care of whatever happens in whichever way is most efficient. Fee-for-service is kind of the exact opposite. So all the doctors who have voluntarily closed their practices to avoid spreading contagion and protect their staff are basically starving for the next month or two. If it's a month or two, people will probably be okay down the road. If it's more than that, it's going to be very, very tough for smaller fee-for-service based practices.
Well, as a solo doc, I'll address that as well. Yeah, it is a challenge financially. I would recommend anyone who is a sole proprietor or independent or has employees, because the SBA loan that is available, that's a significant 8-week cover your payroll for you. So you're right. Temporarily, it's a plus. It's free money from the government as long as you keep your nose clean, spend the money on the right expenses. And 2 months from now, who knows what will be available? They may say that's it, go back to work. I actually have my physician assistant coming to the office starting again next week. She'll be seeing patients there with musculoskeletal complaints and the type of things that I just can't diagnose by video visits. So that'll be a transition as well. In terms of how many work hours there will be will there be 2 full-time equivalents providers 2 months from now? People are losing insurance. It is unpredictable. My goal is to just keep my staff on board full-time, everybody getting paid their regular wages, because every single one of them depend on me financially for their families. So it's just something I deal with. In terms of tips, use phone visits. They're so much more efficient. Even though most of my visits were video visits, I'm sort of learning that the amount of staff time that my staff have to take to make sure that they're signed up with my Hill chart or they're actually functional on WhatsApp. It is time consuming, and for a lot of chronic disease management and the diabetic patients and hypertensive patients, et cetera, you don't necessarily need to see them one-on-one, face-to-face. So I'm probably going to focus more on transitioning some of those visits that for now I've been doing as a video visit to just, unless they're already in WhatsApp and they know how to use it, or else unless they're in my Hill chart. So it will be a transition, but and the other tip I have, I guess, would be, because the government is not going to be auditing and making penalties on physicians who may not have dotted every I and crossed every T on the chart, especially physical exam findings. You don't have to spend a lot of time documenting physical exam findings. As long as you keep the other 2 categories, documented for established patients, you can say the patient looks healthy, and that will meet the requirements. So, nobody's going to go through it with a fine-tooth comb. Be time efficient with your documentation. Review the guidelines that come out regularly by HHS in terms of telehealth codes that are permittable, the G codes that are permittable, screening procedures that are payable. Keep an eye on them both from the Medicare and HHS standpoint, but also from the commercial payers as well. Those are my best ideas.
And that's a great point. Take advantage of this time. If you have a lull in your visit volume, take advantage of this time. You can actually promote virtual annual wellness visits, just concentrating on the health risk assessment and components of that. Just systematize it. You can actually, if you have, currently you probably could get away with it anyway, but if you have a BAA with Google, you can use Google Forms to very easily complete and come back into a spreadsheet where you can collect all the data required for a health risk assessment. Get that stuff done and use that time to review your charts to optimize your appropriate coding for HCC. Go through your chart. Do you have lab data that supports CKD? Do you have chest X-ray evidence of something else? Do that now, so when we hit the ground running, we'll be set up for the value-based care that we need to rocket in.
Yeah, I'm actually doing 4 or 5 AWVs every day And then, advanced care planning and making sure that they've got their post form, going through a living will with them and advanced care directives, and, just getting the conversation going in these people's minds at home. Do I want to be intubated? These are critical questions. And so there's so much value. I mean, the patients are so grateful that we care about them enough to say, let's cover all your bases. These next 5 years, here's what you're going to need to have done for screening. Let's take a look at, what you have set up now for advanced care planning. And many of them don't. So it's really a good opportunity, and revenue wise, it pays better than a regular video visit. So we try to cover, all those bases at the time of that, but we're doing a lot of AWVs now.
Well, we're just coming up on the end of our time here. I wanted to make a couple of quick comments for everybody on the Facebook live stream. First of all, what you might be hearing from the conversation is that there's a technological component and then there's a financial component here. And I want you to know that the Academy is advocating for you on both fronts. So both in terms of ensuring that you get parity for telehealth visits and flexibility to use the platforms you want, but also to move towards true prospective, risk-adjusted, value-based payment. At the end of the day, we want our members to have the flexibility to provide the care that their patients need, to not be thinking about the billing and not be thinking about the logistics of using one platform or another, except insofar as it helps them serve their patient needs. So I want you to know that that's something the AFP is doing, that's something CAFP is doing. A second thing I just wanted to remind you of, everyone in Facebook world, that this is CME accredited. So we've recorded this. We're going to share this recording with our members. Feel free to please share it with your friends and your colleagues, and we'll give you instructions on how to claim your CME credit. I want to say a huge thank you to this panel for being here on your Thursday night. For coming back after the last experience. This has been really educational. This has been really great, and I hope we'll have many more discussions like this. So Dr. Shore, Dr. Rodems, Dr. Connolly, Dr. Zimmerman, and Dr. Brandel, thank you so much for being here. And I thank you also for what you're doing, for your patience on the front line of this pandemic. Really appreciate it.
Thank you.
You're welcome. Our
Thank
pleasure.
you.
Good night, everybody.
Good night. Be strong, everybody.
Yep.
Keep the faith. We can do it.